Hi, everyone. Welcome to the Sign Ask a Neurologist podcast series. My name is Sahdev Baweja. I'm one of the Sign eBoard members. And today I have the pleasure of interviewing Dr. Fabio Danisi. He's Associate Professor of Neurology. Dr. Danisi, thank you so much for coming on today.
A pleasure. Thanks for having me.
Could you tell us a little about yourself and why you chose to become a neurologist?
So early in life, I kind of knew that I wanted to go into medicine. I also have a big love of history and a big love of engineering, but I didn't think history was very practical as a field of study in university, and I didn't have enough of a mathematical brain for engineering, and so here we are. And I decided to go into medicine, which I kind of liked. And in the field of medicine, I was always thinking about something to do with the brain, but I never really had a good idea of what that might be. And I didn't really know that there was a field called neurology specifically, not right away at least. And by the way, I did high school and medical school in Italy. And in Italy, you go straight into medical school right after you finish 5 years of high school. So I didn't have the time to kind of go through college, undergrad, and figure that out. So, I was 18, 19 years old and trying to figure out what I wanted to do. And when I went to attend my first day of lectures in neurology, it's as if I had an epiphany. I saw the light in a sense, and I still remember to this day the classroom and sort of where I was sitting, and thinking to myself, "This is it. This is what I want to do." And in fact, that same day, or perhaps that same week, I went to my neurology professor and I said, "Hey, I want to do my MD thesis with you guys," and so they took me on. I did a project. And so that's really how I got into neurology. It was just very much this vague interest in something brain related, and then the course in medical school really was the clincher.
Okay. And could you also talk about a little bit about your journey post-medical school, residency, fellowships?
So I had lived in the States for a while in elementary school, basically. So I already spoke the language and I already had citizenship. And I decided after medical school to come back to the States. And what I did was I got my USMLE. And after having completed the first USMLE, I started looking at neurology residency programs centered around New York City, really, because I had lived in northern Jersey before I moved back to Italy. And taking advantage that I was going to be in the United States for another reason, I just went to New York City and literally showed up door to door at various neurology residency programs saying, "Hey, do you need a neurology resident?" And I was able to land an internship right away from Italy, and I got a residency as well. I scored well in my USMLEs, that helped. And after I finished residency, I decided to stay on at Mount Sinai, which is where I did my residency, as a movement disorders fellow. Because I found movement disorders fascinating. And this was right at the time when there were new breakthroughs. For example, there were the first case reports of deep brain stimulation being effective for treating Parkinson's disease and essential tremor. And again, one of those seminal moments I remember as a resident, seeing a video of a patient with Parkinson's disease where the DBS was turned on, and you see the immobility and the tremor just completely melt away. And I remember the video, and I remember where it was and things of that sort. So I chose to stay at Mount Sinai and do a fellowship there in movement disorders. I did 2 years there. And after that, I had to decide kind of what I wanted to do. And the first couple of years, I stayed on as a junior attending, as an assistant professor at Mount Sinai, at the School of Medicine there, and stayed on as a junior attending in the medical center. By then, my wife, who had done internal medicine and pulmonary and sleep medicine, was about to finish her sleep medicine fellowship, and we had two small children, one of whom needed special ed. And so we looked around. We really couldn't afford living in the city. And we needed to have a good school district, and we decided to move out to the Hudson Valley. Sorry. We decided to move to the Hudson Valley.
Sure.
And I joined a large group of neurologists, and I was their movement disorder specialist. And I stayed in the Hudson Valley since then. I'm still living in the house that we moved into 21 years ago. Although since then, about 8 years ago, I moved to Westchester Medical Center when they took over at MidHudson Regional Hospital over in Poughkeepsie.
Okay. What conditions would you say you treat, and what are the outcomes you would say generally for your patients?
Well, I generally treat movement disorders. So primarily, the most common condition is Parkinson's disease by far. But because I'm part of a subspecialty practice in movement disorders, I see a lot of atypical Parkinsonian syndromes. So multiple system atrophy, Lewy body dementia, progressive supranuclear palsy, the occasional cortical basal syndrome, as well as some other neurodegenerative disorders and other movement disorders like Huntington's disease, essential tremor, various other chorea disorders, dystonia. At Sinai, I trained quite a lot with someone who was an expert in the field of dystonia and an expert in treating dystonia with various things, including deep brain stimulation, but especially botulinum toxin injections. So I have a lot of patients who I see for dystonia. And then sort of as an outcropping of outgrowth, I should say, of my management of dystonic patients with botulinum toxin, I ended up seeing considerable numbers of severe chronic migraine patients that were referred to me for botulinum toxin injections for their chronic migraine. And this started well before Botox was approved for chronic migraine, which I'm guessing must have been about 10 years ago now, in the early 2010s. And so without wanting to advertise it or anything of that sort or claiming to be a headache specialist, I ended up seeing a sizable number of patients with migraine disorder. And it's ironic because I really didn't want to do that aspect of, practice that particular aspect of neurology. But it's ironic because I get migraines and my wife gets migraines, my entire family get migraines. And so and it's a field that's kind of promising because there's been so much growth in what we can offer patients with chronic migraines, especially the more severe ones. So those are more or less what I generally treat. And then, of course, when I cover the hospital, I see a lot of general neurology, a lot of altered mental status, a lot of stroke patients, and the sprinkling of, epilepsy, meningitis, and so forth.
Thank you. So could you talk a little bit about your work-life balance, what a typical week in your life would be like?
Yeah, well, that changes depending on the phase of life you're in. When you start and you're a junior attending or you're the junior partner in a private practice, and you have a young family and, you have young children and your spouse works as well, you're really burning the candle at both ends badly, and you have no money. And you have to prove yourself and you have to hustle to create a niche, a space for yourself, a professional space for yourself, generate, some buzz about what you're doing, establish a presence in your community. So work-life balance was very much skewed towards work, and whatever crumb of energy was left after work went to taking care of small children. And whatever crumb of energy was left after that, it certainly wasn't going to you or time to see friends or cultivate any interests you might have. Mercifully, over time, your kids get older. You don't have to change diapers. You don't have to, be home when there's a school closure or a snow delay, which was a routine tragedy in the winter because I had to cancel patients or my wife had to cancel patients and we had these kids. It was always a problem, right? So over time, the kids get older. It gets a little easier on that front. And as you get older, you also become perhaps a tad more efficient. Um, Even now, over many years, I learned different tricks in terms of charting, getting things into the patient's electronic medical records. So it becomes a little more manageable. And it's also because, a lot of your work transitions from purely patient care to often as you become more senior in your career as a physician, there's always a little more administrative, and in my case also a lot more teaching. So I have third year medical students rotate all the time at our site at MidHudson. Today, for example, I just returned from New York Medical College in Valhalla, where I taught your second year colleagues clinical neurology course. So a lot of that kind of breaks up the otherwise what would feel like a hamster wheel of just seeing patients every day, 5+ days a week. So work-life balance does get better. It's also very difficult when you start your career to say, no, I can't handle this, because you feel guilty, you feel inadequate. And as you gain experience and maybe a touch of confidence, it becomes a little easier to set limits. And so I think in the past, 5 years since my youngest was, middle school / high school, work-life balance got easier. I actually started exercising, which I hadn't had a chance to do ever really before. And I had more time for myself. I actually can go out and see a friend or two occasionally and dedicate more time to myself, which you need. You really need that, because otherwise you start resenting your work. You start resenting, it's no longer a joyful experience going to work and taking care of people, which it should be. And at its best, neurology is a truly amazing calling, medical field, because you can really make an enormous impact into people's life. But if all you're doing is working and are tired all the time, then of course work-life balance suffers badly, and also professionally you suffer, because you don't come up with fun ideas. You lose the interest in what you do. And so having work-life balance matters also for work, in a sense.
I'm glad it's definitely improved for you over time. What advice would you have for anyone who wants to be a neurologist, who wants to potentially work as a movement disorder specialist?
Well, what advice? Well, neurology is very a very wide field, actually. It's not a narrow field at all. It's a very wide field. So, there are all sorts of ways in which you can go into neurology. You can do the hyperacute medical internal medicine / acute care segment of neurology by becoming a vascular neurologist, or a neurointerventionalist, or a neurointensivist, or a neurohospitalist, which carries a set of particular set of requirements in terms of work-life balance, on call scheduling, what kind of practice setting you'd be in, and so forth, right? You could do something more chronic care, outpatient based, such as neuroimmunology, which is growing beautifully and blooming. Every year there's some new positive development in the world of, for example, multiple sclerosis or autoimmune encephalopathies. Then the same could be said for epilepsy, where you could work both in inpatient and outpatient settings. So there's a whole wide world. In behavioral neurology, the dementias, now we're starting to come out with the first partially effective treatments for the root cause of neurodegenerative conditions like Alzheimer's. There was a recent approval for a drug called lecanemab, which has been shown to slow down slightly but significantly Alzheimer's progression. So there are all these things. The advice is just read a lot about neurology. Attend, of course, make the best of your neurology rotation, and possibly in your fourth year, try to schedule early in your fourth year an external neurology rotation, so that you can get a little extra taste of neurology, either in-house at one of Westchester Medical Center's sites, or even off-site at any large program that you might be interested in, especially if you don't want to stay in the New York City area. And that will go a long way. And whenever you do your neurology rotation, the site preceptors are always happy to help medical students identify where you could go for an external rotation, and introduce you to wherever you want to go, so that you can get in.
Thank you. So you sort of touched on this, but where do you think the field of neurology will be progressing in the next 10, 15, 20 years?
Well, I don't know, because I used to say that I'd be ready to retire when they come out with a quote unquote cure for Parkinson's, or I should say, perhaps an effective neuroprotective strategy, or an effective strategy to slow down or stop disease progression in Parkinson's. I think the field of neurology in general, but to finish that thought, unfortunately, I don't know if that's going to be the case or not, and I don't want to retire when I'm 90. But I think that the field of neurology is expanding very rapidly. And the pace will only accelerate. Just look at a couple of examples that I didn't really talk about before. One is stroke care. For the longest time, there was practically nothing we had to offer for acute stroke. For the longest time, acute stroke, it wasn't even clear that acute stroke was due to thrombosis or embolic events. They couldn't find the clot when they did autopsies. But then in the 90s, intravenous TPA came along, and it made a difference, and made an appreciable difference for select patients within select timeframes. And then in 2015, a series of studies came out showing that select patients with large vessel occlusion responded well to endovascular therapy. And since then, further studies with further refinement of the technique of thrombolysis have shown a remarkable efficacy, with an extremely low number needed to treat, for good outcomes in patients that present with acute stroke. So mid-90s, IV TPA, a lag of basically 20 years, right? From the mid-90s to 2015. And then now all of a sudden we're moving past time windows, and we're really looking at how much tissue is infarcted and how much tissue is hyperperfused but still viable, rather than simplistic time windows. And we have very effective therapies, and more to come. In multiple sclerosis, when I was a resident in the 90s, the hospital would be full of people that would be coming in for MS exacerbations. And MS would be progressive in a very rapid way, in a very aggressive way. And when I was a resident, they introduced the interferons as an immunomodulatory therapy. And those interferons actually made a difference. We started seeing less and less people admitted to the hospital for MS exacerbations. And more recently, there have been developments which have really improved both efficacy and safety of these drugs. And so we're seeing much, much better outcomes now than before. And as I alluded to with neurodegenerative disorders like Alzheimer's, we're getting close to being able to treat the root cause. So the field of neurology will be growing very rapidly in the next 15, 20 years. And it's going to be a fun place to be starting off, because there's still old guys like me that spoke to older guys than me who are, now either retired or dead and buried, who could remember the first time they saw a CT scan of the head.
Wow.
So when I was a resident, the old attendings that, the ones that are about to retire would talk to us young guys about seeing their first CT scan of the head, as opposed to, for example, a neuroencephalogram, right? So on the one hand, I come from the days, which we call the days of the giants, these neurologists like Houston Merritt and Mel Yar and, Bud Roll, and these neurologists that would do these amazing detailed neurological examinations and come to these amazing diagnoses purely based on their clinical skills, to now where we have, biomarkers blooming, for various conditions, where we're going to go from a clinical description-based diagnosis to a biomarker-based diagnosis. And we're going to be able to take advantage of that to start therapy in an earlier manner and hopefully a more efficacious intervention.
It's really exciting stuff upcoming in the field of neurology.
Cool. And it's still a field where you still have to think. Not that you don't have to think in other fields of medicine, of course you do. But, if someone has a intratrochanteric fracture, you get an x-ray, you see the fracture, you fix it. No, with all respect for orthopedics, for example, perhaps the diagnosis is a little more straightforward. Perhaps the treatment approach might be a little more straightforward. We neurologists tend to obsess over things because things are very much nuanced in neurology and tend to be much more complex. The brain is an extraordinarily complex organ, and things can manifest in very, very unusual ways. So we won't be replaced by machines, by AI, or imaging, or blood tests, or neurodiagnostics anytime soon. So there still will be that aspect of the art of practicing medicine in addition to the science of medicine.
That's always good to hear. So for our last question, we'd like to ask everyone who comes on, what is your favorite part of the brain or CNS, and why?
Oh, my favorite part of the brain. Well, you know what? I'll say it's the brainstem. So there, the brainstem. And why? Because it gets no respect, and yet it is essential. You can't go to the bathroom without the brainstem. You can't walk without the brainstem. You can't track objects with your eyes without the brainstem. You can't swallow or have any of the basic functions without the brainstem. So it's such a vital and basic part of the central nervous system, packed in this teeny tiny little area in the posterior fossa, and no one gives it any respect. And yet it's key for so much function of normal function of the brain. And when things go bad in the brainstem, you notice. So I like the brainstem.
Well, thank you so much for your time, Dr. Danisi. We really appreciate it.
A pleasure. Good talking to you.